And we go on to Dr. Mathew Kurian, the Master of Cataract Phaco Surgeon, now from Cochin, and he will talk to us. The IOL is now stable. PCR is over. IOL is unstable. What next?
So this is a very simple situation where the lens has gone through the haptic has gone through the rent which was there. It was rotated a little bit and then gone. The haptics have been pulled. These are multi-piece IOL. So haptics have been pulled up into the sulcus and placed there, and it will be stable there. The rexus was large, so an optic capture could not be done. Next one is flax, where here this is a blunt injury. There is a dialysis superiorly, and it is more apparent during the IA. And at this stage, there was no suspicion that this would be having anything other than a dialysis, so the plan was to put a posterior CTR. But then there is also a posterior capsule rupture, and at this stage what I do, maybe something little controversial, is to place the haptics into the sulcus and do an optic capture through the rexus margin. This was one of the early cases of optic capture in a femto IOL, and it looked in a femto cataract, and it looked very stable. 5 years follow-up is there, and that's good. This is something which Dr. Chitra had just shown, reverse optic capture. But the reason why this reverse optic capture was required was, you see the leading haptic, it was bent over. It should have been straight, and it would have not caused any problem. It was bent over, and so there is a little time as it is unfolding when it is still like a knuckle there. And up to now it looks good, but you can see that when you are dialing, it just goes off very much into the periphery, and that bent knuckle actually hits the posterior capsule and creates a rent. You can see over here that one flap there, which is part of the posterior capsule rupture in the periphery. So at this stage what we do is a reverse optic capture, which just now Dr. Chitra had also very beautifully shown. And this is again a very acceptable and stable method of separating the anterior segment from the posterior segment. Here you can see is a IOL misadventure. The plunger is overriding a large portion of the optic, and the cartridge is stretched. Lot of force is required to deliver the lens into the bag, and at this stage, as the trailing haptic opens, you can see that there is significant amount of trauma there, which I thought would be okay, but 1 week post-operatively that haptic was in the inferior angle with corneal edema, needed to be replaced. This was like government takes TDS, what I call as haptic deduction as source. This is very easy. It's not going to stabilize anyway. You have to exchange this. And one of the methods of explanting this IOL is to use 1S or preferably specialized IOL cutting forceps, which are essential for hydrophobic lenses, where you bisect at least halfway, and then once you've got a 3 millimeter cut, you can sort of rotate the lens out of a 2.83 millimeter lens incision and take it out. What is my preferred method of IOL exchanging now is, in this case, I am not sure what exactly has caused this lens to dislocate so much. So I am making a full SICS kind of wound, do the anterior vitrectomy, clear the vitreous from in front as well as from behind, and I know that there is a large rent there. Once the vitreous is cleared up, I want support, so hold the IOL and then explant it. And now I examine, I could have done this, I should have probably done this initially itself, use the hooks to see what exactly is causing the problem. I see adequate rexus support is there, and the rent is only a small central rent over there. I am able to place the rigid lens in the sulcus. Unstable IOLs, if it is a closed C-loop IOL, you can do an in situ suturing under the flaps. Very old method. Now I use scleral pockets and have gradually moved from temporal, the peripheral to the central approach to a Hoffman's pockets. and here I am doing an in situ bag IOL suturing through the fibrosed portion of the capsule very near the haptic optic junction, and that will give adequate support to stabilize this lens. The 90 Prolene is used and it is sutured and goes into the scleral pocket. This is primarily a CTR was done for a blunt injury. Secondary dislocated, I am putting in a CTS at the area, the CTS is anchored at the area of maximum dialysis, and this is the method of in situ bag IOL complex fixation with capsular segment tension, capsular tension segment or the Ahmed segment, and I have increased the tension too much on one side, the whole bag complex moves to the one side, and I decided to put in a second CTS, and this also goes into the bag and is sutured. Now what has happened is, in order to give good tension, I have put the knots a little bit too tight and it gives way, and about a year later I had to do further gymnastics with this case. And this time, instead of using Prolene, I decided to use more robust suture. So this time it is Gore-Tex. I thread it through the eyelet of the CTS in situ, and this is the entire CTR bag IOL CTS complex refixation, and that also finally ended up giving a stable, decent vision to this patient. Now the question is, are all these gymnastics necessary? It's up to individual choice, and right now, as I have grown older and wiser, I tend to be a little more conservative. So this was glue IOL which was performed, and about year and a half, 2 years after the glued IOL, the haptic has macerated the sclera over there. That sclera is looking quite necrosed, and that haptic has slipped back. So the other side is fixed well. So I've just exteriorized it. There is nothing in which to tuck it, no pocket, nothing. And at that time, flanging, this is before flanging techniques were there. So I just sutured it and put a scleral patch graft to close the place. This is what I do now: support, anteriorize, bisect if required, remove the bag IOL complex entirely, and I do Hoffman's pockets. Thank you, Dr. Sudeep. He's the master of the Hoffman's pocket. And once I do the Hoffman's pockets under a AC maintainer so that the chamber is always pressurized, you can use a toric marker to ensure that it is diametrically opposite, 1.5 millimeters behind the lens limbus, and I make sure that I am using the needle and ensuring that the Sinski is basically to ensure that the pocket extends beyond the area where the needle is entering. And this is my current favorite, the capsular CMT flex goes in through a 2.8 incision. The T-shaped haptic is exteriorized. For the second trailing haptic, I use a handshake technique, hold it close to the T and exteriorize, and use some counter pressure to exteriorize and get the T out. And once you have the T out, go through the pocket with the Sinski hook and gradually draw the T portion into the pocket, so that externally it looks very clean and the T itself closes the hole. One thing that you have to remember is that if you are entering with your hands supinated, it should come, both should come supinated. You should not enter the eye with one hand supinated and come out pronated, because then the lens will be tilted and that's what will happen. It needs to be fixed. Thank you.
Thank you, Dr. Mathew. Thanks for showing all those and telling that when you grow wiser and older, you go more conservative. See, really, everybody should learn from that, and don't make your own mistakes and wait for you to become older and wiser. We become now itself wiser. What is the problem? So believe that lesser manipulation is better, and the technique which works in your hand will give you best results. Don't look at what somebody is doing, let me try that and see, and all those things. So